Again, good day, everyone. Today's session is the other dementias. Alzheimer's disease, of course, is well known, but family caregivers frequently are managing the symptoms and care for loved ones with other dementias, such as Lewy body disorder, frontotemporal lobe dementia, and other less known dementias than Alzheimer's association. Dr. Samuel Brinkman is a board-certified neuropsychologist who primarily works out of Abilene, where he has practice, but he also does a lot of work, I'm sure, via Zoom, as well as I'm sure in person, for the Alzheimer's Association. In his private practice, he provides specialized neuropsychology services for patients with brain-related disorders. He has over 43 years of experience. And again, he has a strong relationship with the Alzheimer's Association, being a frequent speaker for them. Dr. Brinkman has provided us with materials in the form of a PowerPoint presentation that has been converted to a PDF. And if you've not already received that, you will receive it after the presentation. Dr. Brinkman, please. Well, thank you for being here, and please just take it away.
All right. Well, thank you, Xanda, for all the work that you did in putting this presentation together. And thank you to Minerva as well. It is my hope that the information that we cover here will be helpful to each of you participants with the paths that you are walking at this point. I look forward to having the opportunity to address questions that you will have at the end of the PowerPoint presentation. So I'm going to go to my share screen so that I can put the PowerPoint slides on your screens. And let me go ahead and put that up here now. Okay, so hopefully all of you at this point can see that first PowerPoint slide. One of the questions that comes up is what dementia actually means. I think all of you have learned by now that dementia is a very non-specific word that simply means that there has been a loss or a decline in some aspect of mental functioning. Most commonly, we relate that to memory functioning, but it can include other areas of difficulty as well. So the question comes up then, why would we want to differentiate between this dementia or that dementia? And there are three reasons that making a distinction among the dementias is important. First of all, different types of dementias present differently. In other words, the symptoms or the problems that lead someone to seeking help in the healthcare system will differ depending on what the nature of the dementia is. The second reason is that each of the dementias requires its own unique management approaches. And all dementias are not the same in their presentation. They're also not the same in their in the management strategies that are best used. And of course, the third thing is when someone is diagnosed with the dementia, it's important to help a family to develop expectations for what will lie ahead in the future. And so each of these other dementias, as I've called them, excuse me, will have its own unique projected clinical course. So you're going to hear lots of names of different dementias. How do they get the names that they have? Well, there are basically three ways. Sometimes they're named for the person who initially discovered or described the condition. Alzheimer's disease is an example of that. Alois Alzheimer described the clinical characteristics of a lady in her 50s who had the progressive impairment in mental abilities, and the disease essentially was referred to as Alzheimer's disease, meaning the disease that Alzheimer has described and studied. A second naming approach is that the condition will be named after the brain region that's involved. An example of that would be frontotemporal dementia. And the third, the condition may be named for certain neuropathological characteristics. So we might talk about a prion disease, and we'll talk briefly about that a little bit down the line. Overall classification of dementia, I can't emphasize enough that not every dementia is irreversible. There are a number of conditions that are reversible that can cause dementia, and once the disorder is identified and treated, the dementia will improve as the underlying condition improves. It is thought that about 20% of individuals over the age of 65 with recent onset of memory or similar impairments actually will have a reversible condition. Then we have the irreversible disorders, and these are, of course, of greatest interest because this is what we'll be talking about today. And then a subset of conditions that we may refer to as partially reversible disorders. So the irreversible dementias can be placed into each of these four categories. The degenerative disorders are named because you have progressive degeneration of brain tissue. The vascular disorders are named because the essential problem is not one of the brain tissue itself, but it's about the circulation or the delivery of oxygen and nutrients to brain tissue, causing the brain tissue to not function optimally. The third is under the heading of traumatic disorders. This refers to brain trauma, not psychological trauma. And then the fourth category would be combinations of the above, generally referred to as the mixed dementias. So of the degenerative disorders, as you know very well at this point, Alzheimer's disease is the most common. The second most common is Lewy body disorder, which also includes something that had traditionally been referred to as Parkinson's disease dementia. The frontotemporal dementias, a disorder called progressive supranuclear palsy, another one referred to as multiple systems atrophy, Jakob-Creutzfeldt disease, and Huntington's disease. These are some of the conditions that we'll be talking about today. So Alzheimer's disease is the most common, and the Alzheimer's Association estimate is 6.7 million cases in the United States. What happens with Alzheimer's disease is an abnormal protein. The normal protein is called amyloid. Its abnormal form, beta amyloid, tends to aggregate or clump together to cause plaques. And it's these beta amyloid plaques that have been the hallmark of Alzheimer's disease. But the other key part of the disease process with Alzheimer's disease is abnormalities of the tau protein. This is a protein that lives on the axon of the brain cell and has a role in managing the flow of material up and down little microtubules that are in that axon. When the tau protein becomes hyperactivated in Alzheimer's disease, that membrane breaks down and the neurotubules form what are called neurofibrillary tangles. Alzheimer's disease is characterized by problems of memory, amnesia, problems of language, which we refer to as aphasia, problems of perceptual processes, which are referred to as agnosias, and complex task performance, which is referred to as apraxia. And then there's this last category of impairment referred to as executive functioning, and we'll come back to that in a little bit. The greatest risk factor for Alzheimer's disease, as you know, is advancing age. The estimated life expectancy varies depending on who you ask. I see some estimates as low as 6 to 8 years. I tend to go with 8 to 12 years, but that depends on how late in life the symptoms present. If a person is in mid-80s before onset of Alzheimer's disease, of course, the life expectancy from that point forward will be lower than someone who is in early 70s with onset. And in Alzheimer's disease, 2/3 of the patients are women. So that's about all I'm going to say on Alzheimer's disease, because this discussion is about all of the others. And that will take us to Lewy body disorder, or dementia with Lewy bodies. So here we have a disease named after a European scientist named Lewy, L-E-W-Y. And he was a contemporary of Alois Alzheimer and lived a little bit after Alzheimer. Lewy body was described some years after Alzheimer described the changes in his classic patient. Lewy body disorder is thought to be the second most common of the dementias, of the irreversible dementias, and is estimated at 1.4 million cases in the United States. Basically, there are two groups that are subsumed under the heading. One is the classic or traditional Lewy body disorder, and the other is the Parkinson's disorder with dementia. With Lewy body disorder, again, we're looking at a degenerative process that is tripped off by an abnormal protein structure called alpha-synuclein. And these abnormal proteins form what are referred to as Lewy bodies. This term body is a term that neuroscientists use to describe an element or a structure that is inside or in the vicinity of a neuron where it doesn't belong. So Lewy body means these alpha-synuclein proteins have created these structures or bodies that exist where they don't belong and were described by Lewy. So Lewy body disorder. The classic features that separate Lewy body disorder from the more common Alzheimer disorder are listed in the next line. Of course, there is dementia with it. Lewy body disorder often is associated with something called a REM sleep behavior disorder or REM sleep disorder, sometimes called dream reenactment. This symptom refers to a tendency during sleep to physically act out the dreams. Normally in REM sleep, the body is not active at all. The muscles have very low tone. But in REM sleep disorder, the legs may move or the hands or arms may move in what would appear to be a purposeful fashion. Some of you that are in my age group that remember cartoons on TV when they were really good may recall a picture of a cartoon of a dog sleeping and dreaming about chasing a cat, and the dog's legs are moving as it's dreaming about chasing a cat. So that would be an example of REM sleep disorder. Another distinguishing feature of Lewy body disorder is visual hallucinations. This is something that's also seen in Parkinson's disease. So a hallucination means a perception of something that's not really there. And in this case, Lewy body disorder nearly always involves visual hallucinations. Rarely there may be auditory hallucinations as well. So in essence, this person is seeing something that's not there. In contrast to the hallucinations that are associated with schizophrenia, with Lewy body disorder, the hallucinations are not especially upsetting, they're not especially threatening or scary to an individual. Most commonly, they are people in places where they don't belong. So someone may see people in their house when people are actually not in their house. They may see people in the lawn. Somewhat less frequently, small furry animals. So somebody might see a raccoon or a cat or a rabbit sitting on the furniture in the house. So the visual hallucinations are not seen in Alzheimer's disease, except under very unusual circumstances. So when the visual hallucinations like this occur, it makes us think more about the possibility of Lewy body disorder. The third feature of Lewy body disorder that distinguishes it from Alzheimer's disease is that it's associated with much more day-to-day variability than Alzheimer's disease is. So a patient may look so good one day and be unbelievably impaired the next day, and then return to a much higher level of functioning the day after that. So the clinical characteristics of Lewy body disorder, the REM sleep disorder, the visual hallucinations, and the day-to-day variation make it clinically distinguishable from Alzheimer's disease. Lewy body disorder affects men more than women, but it's not considered a genetic disorder. Typically, onset of the disorder is after 60 years of age, and very seldom seen under 60 years of age. And life expectancy is highly variable, and general estimates are the life expectancy with Lewy body disorder will be 6 to 12 years from the time of onset of symptoms. Now we look at frontotemporal dementia, and obviously this one is named based on the structures of the brain that are involved in the degenerative process. The front parts of the brain or frontal lobes and the temporal lobes, which are along the sides of the brain. So frontotemporal dementia is characterized by atrophy or loss of neurons in the frontal and temporal lobes of the brain. There are actually several different disorders in this category of frontotemporal dementia, and the symptoms depend on which areas of the temporal lobe or which areas of the frontal lobe are degenerating. Some frontotemporal dementia cases may be associated with certain abnormal proteins, and prion disease would be an example of this. But overall, we would look at three categories of frontotemporal dementia. The first is the variant that involves primarily behavioral and personality changes. Let me check my notes here so I don't get lost. The second is the variant that involves primarily language changes. And the third is a somewhat uncommon variant that involves abnormal movements. And some people will put this condition, progressive supranuclear palsy, in that category. So let's look at each of these. The behavioral and personality change variant of frontotemporal dementia. Symptoms tend to be gradual in onset and tend to be pretty smoothly progressive, in contrast to Alzheimer's disease, where the symptoms predominantly involve memory and then language, such as word finding problem and agnosias and apraxias. With the behavioral and personality variant of frontotemporal dementia, the changes seem to involve things like motivation, complex social judgments, impulse control, and behavioral and emotional control. And so often with this variant of frontotemporal dementia, the patient is suspected of having a psychiatric disorder or a personality disorder or something like that. And it's only with time where it becomes gradually more clear that the frontal and temporal lobes of the individual are experiencing very significant degeneration. So in this category, people will do things that are not in their normal range of social behaviors or value-laden behaviors. It would not be unusual, for example, to see changes in temperament, a tendency to anger more easily or to become suspicious of others. There may be sexually inappropriate behavior, such as sexual comments to people that the person would not normally talk that way with. There may be problem of simple impulse control, and in the sexual range, this may be inappropriate touching or things along those lines. In other areas that may involve inappropriate eating, simply excessive eating. You know, the traditional seafood diet, if you see food, you eat it. A person may not be able to achieve a point of satiation and simply eat until the food is gone. And of course, the behavioral and emotional control variants would involve these things. In general, with this variant of frontotemporal dementia, these types of personality and emotional changes tend to precede changes in memory or other cognitive abilities. So the person does not have language disturbance. The person does not seem to have problems of memory, but it's the behavior that has changed. And again, the behavior changes that are seen represent a departure from the person's long-term personality, behavioral, and social characteristics. A normally shy or introverted person may become very outgoing, or a very gregarious, outgoing person may become more introverted and shy. Often you'll see bad financial decision-making. I can think of a particular case of a fellow that was a rancher who went to 2 different dealerships and bought 2 $250,000 tractors on the same day when they did not need it on the farm. So the bad financial decisions may be a part of what's seen in this behavioral and personality variant. Now going to the next one, progressive supranuclear palsy. This is actually a fairly rare disorder, perhaps 20,000 cases per year. If we look at this term, progressive is, as the name implies, it is gradual in onset and worsens over time. Supranuclear refers to the cranial nerves. There are 12 cranial nerves down toward the bottom part of the brain. And these cranial nerves each have important functions. Some of them will innervate the tongue or the lips. Some will innervate the sensory areas of the face. Some will innervate the portions of the pharynx that's involved in swallowing, for example, or regulation of eye movements. And so the symptoms that you see with progressive supranuclear palsy tend to be either speech changes, such as maybe a more hoarse quality to a person's speech pattern, sometimes called dysphonia or aphonia. There may be swallowing problems. A person may tend to choke more easily while swallowing, including clear liquids like water. There may be visual changes, such as difficulties with the horizontal gaze. In other words, moving the eyeballs side to side, or with problems regulating a downward gaze. There may be frequent blinking because these blinking movements are regulated by cranial nerves as well. There may be a tendency to fall or to lean backward. And there also may be emotional outbursts. And this is something referred to as pseudobulbar affect. Affect refers to emotional expression. Bulbar refers to the cranial nerves. Pseudo means false. So a person may cry or laugh almost uncontrollably, even when the person is not feeling sadness or other kinds of emotions that would make one cry, or the emotions that would make one laugh. So you see the external expression of the emotion, because a lot of that's regulated by the cranial nerves, but this occurs without the emotion that normally would accompany that expression. So that's progressive supranuclear palsy. Life expectancy is short. It's about 3 to 6 years with this disorder. I'm going to switch now to other degenerative disorders, and each of these is interesting in its own unique way, and are probably more of academic interest than for most of you, because they are not common disorders. The first one is called Jakob-Creutzfeldt disease. Jakob and Creutzfeldt were European scientists who were looking at degenerative disorders of the brain, and the thing that makes Jakob-Creutzfeldt disease interesting is it was the first degenerative disorder of the brain that was proven to be transmitted by a virus, actually. You may be more aware of the bovine variant of this, so-called bovine spongiform encephalopathy, which goes by the general name of mad cow disease. And so Jakob-Creutzfeldt disease, the contribution in identifying it is that it was demonstrated to be transmitted by a virus. Again, it's quite a rare disorder. It's an especially rapidly progressive disorder as well. Huntington's disease. Huntington's disease is of interest mainly because once the inheritance pattern or the gene was identified that predisposed to Huntington's disease, it was possible for individuals who were carriers of that gene to make the decision to not have children. And so by decreasing the transmission of that gene over generations, what we're seeing is a marked decrease in the frequency of cases of Huntington's disease. I have seen occasional cases, and these patients are quite a lot older now, but I have not seen a young adult or middle adult case of Huntington's disease personally in many years. The onset of symptoms tends to be in the 40s, and what's important to note there is that by 40 years of age, most adults have already made the decision to procreate and have already had children. And at the point that they would have the symptoms of Huntington's disease, the gene was already transmitted. So the identification of that gene in a carrier before they came to the decision to reproduce has markedly decreased how common this disease is. Huntington's disease is a disorder of part of the brain called the basal ganglia. which is also in the area where Parkinson's disease is located. And with Huntington's disease, you see certain atypical movement patterns. They're sometimes called epileptic movements, or sort of a ringing motion of the extremities, for example, maybe choreiform movements. And of course, dementia is seen with that. And then this last one under degenerative conditions that I'm going to list is multiple systems atrophy. This one used to be named after a European scientist and was called Shy-Drager syndrome. And you still see that terminology occurring in neurology textbooks, but more commonly referred to as multiple systems atrophy at this point. And the multiple systems atrophy simply means that multiple systems of the brain are degenerating. And the thing that distinguishes multiple systems atrophy, you'll see some Parkinson type features with it, but it involves dysregulation of the autonomic nervous system. So we'll go back to high school biology quickly. The autonomic nervous system is that part of the nervous system that regulates normally unconscious body processes like heart rate, heart rhythm, respiratory drive, blood pressure, and things like that. The sympathetic nervous system, which is part of the autonomic system, is involved in a rapid increase in these activities, sometimes known as the adrenaline rush, since adrenaline is the neurotransmitter that's used by the sympathetic system. And then after that, the parasympathetic system slowly calibrates the heart rhythm, let's say, or blood pressure, or whatever it may be, back to its normal homeostatic place. So with multiple systems atrophy, this dysregulation of the autonomic nervous system can cause severe medical emergencies. For example, I don't know where all of you are, but in Abilene, we are in the mid to upper 100 degrees every day these days. And so a person going from that outdoor heat into an air-conditioned room, that activity can precipitate dysregulation of the autonomic nervous system and a medical crisis. Okay, now we'll turn to vascular dementia. This was once thought to be very common. If you look at neurology textbooks from the time that Alzheimer described the disease named for him in the first decade of the 1900s, on up to the 1970s, Alzheimer's disease was described as a rare disorder affecting people in their 40s and 50s. But two major research studies out of England actually demonstrated that older people over the age of 65 that have dementia, the overwhelming majority of those actually had Alzheimer's disease rather than so-called hardening of the arteries of the brain, which we would call vascular dementia now. So vascular dementia is not as common as it was once thought to be, but there are thought to be about 200,000 cases per year in the United States. The development of vascular dementia typically is associated with evidence of circulation problems in the brain. These may be TIAs, sometimes referred to as mini strokes, or completed strokes. The symptoms are variable depending on specifically where in the brain the circulation problems are occurring. If they occur in a language structure, then you see language symptoms. If they occur in structures that involve perception, then you see predominantly perceptual problems. Characteristic of vascular dementia is a stepwise progression. So with Alzheimer's disease, we think of a very slow, gradual onset, slow, smooth, steady progression. With vascular dementia, you tend to see a stable level of functioning and then a quick reduction, followed by a slight improvement and another quick decline in level of functioning. Risk factors for vascular dementia are the same as the risk factors for cardiovascular disease, and they're listed here: diabetes, hypertension, high cholesterol, smoking, heavy use of alcohol, conditions like atrial fibrillation. So these are the things that place a person at risk for vascular dementia. Now the traumatic disorders, and I'm going to list two categories here. One is if a person has sustained a traumatic brain injury, there can be long-term deficits in cognitive functioning, that would be dementia, as a result of that brain trauma. The changes tend to be fairly static over time unless new problems come up inside the brain, such as hydrocephalus or epileptic activity or something like that. So a single traumatic brain injury can produce long-term deficits. The other is progressive changes following a history of multiple mild traumatic brain injuries. And some of you doubtlessly have heard of chronic traumatic encephalopathy. There's so much talk about the number of concussions that athletes have. Football players, especially in the offensive line, are at risk because of the number of blows to the head that they sustain. There's a lot of interest in soccer and the number of headers that a player will do over the course of a lifetime. So this is chronic traumatic encephalopathy, and a description of that, again, those of you who remember a great boxer, Muhammad Ali, saw him in his rare television appearances have Parkinson's type features as he was walking, and he was slurring his speech, and he was having significant memory problems. That is an example of chronic traumatic encephalopathy. It used to be called the punch drunk boxer syndrome, or dementia pugilistica was its original term when described by a couple of British researchers, especially a fellow named Corsellis. If you've ever seen the Will Smith movie Concussion, that actually is about the development of a traumatic cause to dementia. And then this final category that we'll talk about are mixed dementias. We've talked about several different types of dementia, but in reality, different types of dementia can exist in the same person. Not uncommon is to see Alzheimer's disease plus vascular dementia. So just the fact that a person has had a TIA or mini stroke doesn't mean they have vascular dementia. They may have Alzheimer's disease plus vascular dementia. Another example would be Alzheimer's disease plus a traumatic brain injury. It's not uncommon for a patient, an older patient, to fall and strike the head and perhaps have brief loss of consciousness, perhaps not, but perhaps have brief changes in mentation, and then have a progressively declining clinical course from there. And so what we often would see there, and what we would hypothesize, is that the Alzheimer's disease was in the process of developing. Remember that Alzheimer's disease develops for over 20 years before symptoms show up. And then coincidentally, a fall and a blow to the head occurs, unmasking the Alzheimer's disease a little earlier than it otherwise would have presented. And then, of course, Alzheimer's disease together with Lewy body disorder as well. Given that those are the two most common degenerative causes of dementia, it would seem reasonable to see them occur together in the same individual as well. So a person who shows a classic picture of Alzheimer's disease with memory impairment, some executive dysfunction, some word finding problems, some tendency toward visual confusion, which is a perceptual deficit, might then eventually develop REM sleep behavior disorder, visual hallucinations. And so one would suspect in that case the combination of Alzheimer's disease and Lewy body disorder. So these are all of the conditions that I planned on going over with you. And I wanted to leave plenty of time for questions and answers. So let's go ahead, and if you would mind to identify yourself and then ask your question. Hopefully my hearing aids will be working well enough for me to hear what you're asking. I might add, hearing loss is one of the reversible causes of dementia. So what questions do you have on any of these topics?
I'm not seeing anything in chat, but while people are gathering their thoughts, here we've got Minerva's asking, what about chemical exposure contributing to dementia, such as Agent Orange? Where would that be included?
Yes, I'm a Vietnam veteran, and I know that I had some Agent Orange exposure. Fortunately, I've not had symptoms from it, thank goodness. But yes, chemicals in a lot of different ways can cause dementia. Let me reset my thing here. And among those would be pesticide exposure, organophosphate pesticides, for example, heavy metals, lead, mercury, arsenic, things like that. Certainly Agent Orange, which also tends to produce a picture of Parkinson's disease as well. So the various industrial solvents and things like that can also cause dementia. In taking a history of somebody who presents for evaluation of dementia, I always like to go over what are the potential toxin exposures that might have precipitated the dementia. To some extent, these may be reversible depending on which ones and how severe the exposure is.
Another question, can hydrocephalus cause dementia?
Hydrocephalus is listed as one of the reversible causes. Now, there are two broad categories of hydrocephalus. One of them is where the flow of cerebral spinal fluid through the various cavities of the brain actually becomes obstructed and pressure inside the head increases, causing dysfunction and eventually irreversible damage to brain tissue. And this is the one that you normally see in childhood. The more common one that you see as a cause of dementia is called normal pressure, which is actually an incorrect word, normal pressure or communicating hydrocephalus. And in this condition, there seems to be some loss of communication between the structures that produce cerebral spinal fluid in the brain and the structures that absorb the fluid, so that there is intermittently too much fluid. You know, all of the fluid that we have in our brain is replaced about 4 or 5 times a day. So there's a steady process of producing the cerebral spinal fluid. Normal pressure or communicating hydrocephalus is characterized by 3 symptoms. The first is, of course, the memory impairment. The second is a change in the walking pattern. It's called a broad-based gait. If you watch someone walking and think about how far apart their feet are laterally with each forward step, the feet are much farther apart, so a broad-based gait. And then the third characteristic is loss of urine control or marked increase in urinary urgency. And that's caused by long fibers that inhibit the bladder being stretched as the ventricles of the brain that contain the cerebral spinal fluid are enlarged.
Okay. You mentioned,
good question.
You mentioned children. This is appropriate. Would an early brain tumor surgery develop into several dementias when the person was 19 and at 75 has many issues?
You know, the general thought is that anything that impacts on the brain in a negative way can potentially increase the risk of developing dementia. Now, with respect to that tumor, there are a number of different types of tumors, but if that tumor was treated surgically and they had a good extraction of the tumor and there was no recurrence of it, then I would not expect that tumor to cause dementia down the line. But if that tumor was more infiltrating in nature and did produce changes in the connectivity of the brain and of major structures of the brain, I could see that that would increase the risk of developing dementia decades later.
Okay. Is frontotemporal dementia hereditary?
Generally speaking, no, but there is a subcondition. I'm going to give you the name of another European scientist. His name is Pick, P-I-C-K. There is Pick's disease, which is seen much more commonly in some families. So it is thought to have a very strong genetic component. Pick's disease tends to be associated with the behavioral and emotional variant of frontotemporal dementia, and has onset in the 40s and 50s.
This is getting a little bit away from the specific disorders. However, what do you recommend for older adults and caregivers who are in denial about the disease? And a follow-up question is, what doctors do people need to see? Because there are a couple of questions about diagnosis.
Okay, yes, let me go ahead and address that. First of all, a person may not be aware of the condition for different reasons. For some people, it simply is psychological denial or psychological avoidance. You know, if that's been sort of the personality style over the years, it would not be surprising to see that when memory impairment develops. But the other is, the term for it is anosognosia. Anosognosia is a condition in which the parts of the brain that monitor functioning of the rest of the brain becomes disordered. So a person really and truly does not know that they are not remembering correctly. In a case like that, often the patient will become irritable or angry with people for telling them they're wrong all the time when they are 100% certain that they are right. But that would occur with this condition called anosognosia, or the self-monitoring deficit. This is a part of what I refer to in the Alzheimer's slide as executive dysfunction. This is an aspect of executive dysfunction. Again, not unusual in Alzheimer's disease as things progress, for the person to have, the person with the disease to have very poor, very limited awareness, while the family has great awareness and sees the patient as being uncooperative or unhelpful. So what do you do in that situation? Well, you just lovingly persist. You don't want to nag a person day after day after day, but you do want to get the appropriate diagnostic studies done to be certain that this is not one of those reversible conditions. So it is imperative that this condition come to the attention of the primary care physician. So I recommend starting with the primary care physician. There are there's a standard protocol for labs and for an imaging study, the studies that need to be done to rule out things like thyroid dysfunction, B12 or folate deficiency, some type of an infection such as a urinary tract infection, some kind of liver disorder, kidney disorder. There are many, many things that would need to be ruled out before concluding that it's an irreversible condition. And that would include an imaging study, CT or MRI of the brain. So it is important that those studies be done, whether the patient agrees or does not agree that there's a memory problem. It's important as part of the annual physical that those studies be done. In certain cases, especially if it's a young, early onset case, someone in their anywhere from upper 40s on up to low 60s, it may be necessary to have a neurologist involved there as well. And especially with the younger one, I would want a neurologist to confirm or refute the diagnosis. If there are certain symptoms that occur with it, for example, seizure activity or something like that, of course, a neurologist should be involved. Does that address that question adequately?
It does. And if I understand correctly, and what I've always heard before, you approach the person that you're concerned about is more in terms of not the memory issues, but we want to make sure that you have the best health care available. And we have some concerns. And so it's time to just do some testing like we do throughout our lives.
That's correct. And Medicare has mandated that there be once a year screening of memory functioning as part of the annual wellness physical. Now, the screening that's actually done is not necessarily the most sensitive to the changes, but at least it is happening more now.
Well, okay. Someone has written, thank you for the work you do. Karen Evans wrote that. Another question, let me get down here. And also Melody said that. I think you've addressed this, but is there anything you want to add? How do they know for sure what type of dementia that you have after all of that testing?
It's a clinical diagnosis. By that, I mean, there's not one study that will say absolutely 100% this is Alzheimer's disease, or this is frontotemporal or Lewy body disorder. So it is based on the clinical features for all practical purposes. In the larger referral centers, there are studies that can be done, for example, an MRI that will measure the volume of the hippocampus, the memory structures of the brain, or there's a study in which a PET scan can be done while administering an isotope that will cling to the beta amyloid plaques. And that will increase or decrease the certainty. There's increasing use of certain blood indicators or cerebral spinal fluid indicators. This means you would have a spinal tap that would look at levels of beta amyloid or tau protein as well. And so there's some progress there, but you cannot be 100% certain without tissue under the microscope.
Eric has asked, if one has been diagnosed with Huntington's disease, does that always lead to Alzheimer's also?
No, actually, in Huntington's disease, patients don't live typically into the age range of greatest occurrence of Alzheimer's disease, but Huntington's disease will be associated with its own dementia. And so it's theoretically possible that someone could have Huntington's disease and then subsequently develop Alzheimer's disease, but I would think of that as a pretty rare event.
Anouk has asked, is Lewy bodies the same as Parkinson's?
They are similar. I would put on a continuum at one end Alzheimer's disease, at the other end Parkinson's disease, and I would put Lewy body disorder in the middle. It has some symptoms of Parkinson's disease, the movement difficulties, the visual hallucinations, for example, but it also has symptoms associated with Alzheimer's disease, that being the dementia, the marked change in memory and other similar functioning. So, I jokingly refer to them as cousins. They're all three degenerative disorders. They have some symptom overlap, but the actual diagnosis is a clinical one, and the Parkinson's disease, which later develops dementia, would be considered under the heading of Lewy body disorder, but not the classic case of dementia with Lewy bodies.
Okay. Sonia has asked, did we address this? Can you have vascular dementia? We haven't. And traumatic brain injury? Yes,
you can, absolutely. Of the traumatic brain injury, there would be some history of trauma to the head, and normally you would expect to see something post-traumatic. For example, loss of consciousness, concussive type headache, maybe visual disturbance. There may be some memory disturbance, some slurring of speech, word finding problems. So the trauma itself would exist independently from the circulation problem in the brain.
Okay. Andre has asked, many years ago, the consensus was that as soon as you had a history of stroke or TIA or any sign of vascular brain damage, the diagnostics was mixed dementia and therefore could not be categorized as Alzheimer's. Does this consensus remain?
They would not be considered Alzheimer's alone, but you could see the coexistence of Alzheimer's and vascular dementia. And the significance of that is this: if there are medications that are geared specifically to Alzheimer's disease, and someone has a history of a TIA or a stroke, would you withhold that Alzheimer's specific medication? My thinking would be no. Now, we have these new medications that decrease beta amyloid plaquing in the brain. They do have some side effects that are of concern, but if those side effect profiles become milder, I would be very happy using a medication like that or recommending a medication like that for somebody who has Alzheimer's disease and has a history of a TIA.
Okay. We have a question that I think is going to be of interest to a lot of people. Gina is in Mobile, Alabama, and she hasn't been able to find a helpful doctor in her area. Any suggestions, and can you broaden that? How does one find a specialist who can adequately address or diagnose what's going on with someone?
Well, family practice, primary care, internal medicine, these specialties routinely do these types of evaluations and do these diagnoses. So any primary care physician ought to be very competent for doing the appropriate workup. That being, the appropriate labs, taking the history, reviewing medications, ruling out medication side effects, for example, and doing the imaging study to rule out things like communicating hydrocephalus. So any primary care physician ought to be able to take it that far. And then at that point, if there still is uncertainty or unusual circumstances, then just get a neurologist to review the case and do an evaluation as well.
Okay.
But a primary care physician should be very competent at doing that workup.
Okay.
And if they're not doing it, get another one.
Right. And some of that testing will be part of the annual Medicare evaluation.
That's correct.
So that is at least helpful. And again, the way you approach someone is, it's time for your yearly. We need to take care of some things. And I used to send faxes to my mother's doctor describing some of the symptoms. So and she actually the physician came out once and said, you don't know how helpful that was. Mm-hmm. So just kind of, you're not sneaking around behind their back. You just want to make sure that they have the best care. Also, would you agree?
And if you, Xanda, if you will allow me just real quickly to go back to the question from the person from Alabama, get with the Alzheimer Association office.
I was just going to mention that.
Yes.
They have a list of physicians in the area, even attorneys that are elder law. They're a valuable resource.
Absolutely.
And the Area Agency on Aging, and I'll refer to that later, they would also have some good insight, but start with the Alzheimer's Association. Karen says, is there a way such as diet, exercise, vitamins that can help prevent Alzheimer's? As you say, it has a course of progression of about 20 years.
The word prevent is probably not the best word to use, although that's the word that you tend to see in the lay press, newspaper articles and things like that. I would refer you to the FINGER study, the Finnish geriatric study of something, I don't remember the rest of the acronym, but basically they looked specifically at the interactions among physical activity level, regular physical exercise, social interaction, mental stimulation, and good nutrition, and found that combination of things had a very significant impact on delaying the development of Alzheimer's disease. And basically, you would like to delay it until the person dies of something else, Now, the only thing I would add to that is good quality sleep on a regular basis and taking care of things like depression and anxiety as well. This FINGER study is being replicated in a large number of industrialized nations, including in the United States. And the acronym there is the POINTER study, POINTER. And so you might simply track that online. But the 5 lifestyle conditions that I emphasize: physical exercise, social stimulation or interaction, mental stimulation, good nutrition, and good quality sleep.
Connie's asking, how significant is a multiple factor decline in Parkinson's with dementia? Almost complete loss of walking ability, often near total executive loss, inability to find words and answer questions.
Yes, and what you're describing there is Parkinson's dementia. If the person had the diagnosis of Parkinson's disease, you're looking at the category of Lewy body disorder.
Okay.
When you get decreased mobility for whatever reason, whether it be due to peripheral neuropathy or osteoarthritis or things like that, when you have reduced mobility, You have reduced sensation due to things like hearing loss, visual loss, and then just so markedly reduces overall mental stimulation that alone can lead to progressive dementia. But if you take care of your vision, take care of your hearing, maintain as much mobility and activity as you can, then you can mitigate against the effects of those things.
Okay. Donna says,
I'm going to have to get to my waiting room in just a minute.
And I was going to suggest, let's let this be the last question. And
Okay.
do you mind if we send you some questions? And as you have time, you could email me or.
Sure, Zenda, I think that would be just fine.
Okay. Donna says, are syncope episodes part of a specific type of dementia? And
I'm sorry, say that first part again. I didn't hear that.
Are syncope.
Oh, syncope. Okay.
Episodes part of a specific type of dementia? And would you define syncope for?
Yes, syncope is a sudden passing out episode. And normally it's very brief. It's not dizziness, it's not vertigo, but it's a sudden passing out. And it typically will precipitate a cardiac workup as much as anything. And so given that cardiac problems can be associated with vascular dementia, I would say that a syncope episode may alert to increased risk for developing vascular dementia, but the person would need to have a workup, make sure that major arteries are patent, that they're not too narrowed down, make sure that there's not a heart rhythm problem, make sure that there's not a potassium sodium problem. There are many things can cause syncope. It will be important to get to the root cause of it and then address that root cause.
Okay, and I'm sorry to say the next person's that we're going to have to cut it off here because he does need to go. But and it's a very long question, needs probably some thought anyway. What we will do is we will forward him these questions and we'll get back with you with the answers. Thank you so much. So many comments that people have made about how helpful this was. We know it's a lot of information, folks. Before we leave, I want to quickly refer you to the Alzheimer's Association, your local area agencies on aging. You can reach both of those through dialing 211 across the United States, and something called Elder Care Locator, which also you can just put that into your web browser, and that is also and I'll put that in the questions, the answer to the questions also, so you have that. Thank you, sir, so much. Thank you, everybody, for listening in, and I appreciate your
I'm sorry, real quick, can you spell syncope?
SYNCOPE. It is in the question that was posed by Donna Spencer, if you're looking at the chat.
Okay, I couldn't find it. Okay.
Again, thank you, Dr. Brinkman. Are there any last comments you want to make?
I'm sorry, say that again.
Are there any last comments you want to make?
Oh, no, just thank all of you for participating. You're strengthening yourselves and you're making the pathway for your loved ones much easier by taking the time to do this. So thank you. And
I already have a topic to talk to you about for next year, the chemical issue of what the research is showing, not to get into the legal parts, but what you talked about, toxins. So that can be a discussion we can have at another time. Thank you, everyone. And look for the answer to the unanswered questions. Have a great day.